Hello everyone. So the topic that we're going to discuss today is subcutaneous mycosis. And what do you understand by subcutaneous mycosis? So subcutaneous mycosis usually are the ones which are caused by traumatic inoculation, and it involves subcutaneous tissue. So if you remember, we've been reading about superficial mycosis, where we've spoken about dermatophytosis, but these usually involve only the keratinized areas. But now we're talking about the involvement of subcutaneous tissues. So what do you understand by this? So when I say subcutaneous tissues, I am referring to the involvement of this particular area along with the epidermis and dermis. So when we were talking about superficial mycosis, we were only referring to the involvement of this particular layer. But when I am discussing subcutaneous mycosis, I am talking about the involvement of the subcutaneous layer as well. Now, what are the various conditions that you have to know for this? What are the various conditions which are commonly seen? Now, the most important one is mycetoma. So, mycetoma is an important subcutaneous mycosis. Rhinosporidiosis is another important condition that you will also get to know. Chromoblastomycosis and Sporotrichosis. Now, Sporotrichosis, like I told you, there is an entity which is known as dimorphic fungi. So, dimorphic fungi, one of the most important examples also happens to be Sporotrix shenkai. Now, coming to the lab diagnosis, which is the most important one. So, when we are discussing mycetoma, just a brief introduction of what mycetoma is. So, when I say mycetoma, I am referring to this particular condition, which is nothing but a slowly progressive condition. It's very slowly progressive, and it involves the subcutaneous tissue, like I had already told you. Now, it involves a triad that you have to remember. So what are the triad? What is in fact the most important thing? So what is a triad is nothing but you have tumor-like swelling. So there is tumor-like swelling, which is the first important one. Second one happens to be you have discharging sinuses. So this is your discharging sinuses, which is your second important triad. And third happens to be the discharge of what is known as granules. So you have to remember that granules are being discharged from this particular site. So you will have tumor-like swelling, discharging sinuses, and granules which are discharged from this particular sinuses that we are referring to. So mycetoma is nothing but a triad of these three symptoms. Now, what is the other things that you have to remember? It is divided into what is known as actinomycetoma and eumycetoma. Now, actinomycetoma is the one which is involving bacteria. So you have bacteria which is involved in actinomycetoma. So you will see numerous swellings, numerous sinuses with purulent discharge. But the thing that you have to remember here is the color of granules. And if you remember here, you have something which is known as white or yellow granules which are normally seen. Now the most important organism to remember here is Actinomadura madurae. Nocardia species are also involved in actinomycetoma. So this is what you have to remember. So actinomycetoma is the involvement of bacteria causing Madura foot, and eumycetoma is when fungus is a cause, where you normally see single sinus and swelling. There is serous discharge and black granules are very typically seen. Now the most important ones to remember under eumycetoma is what is known as your Madurella griseae and Madurella mycetomatis. So Madurella mycetomatis is one of the most important ones to remember in this particular category. Now there is another one which looks extremely similar to your mycetoma, which is also known as Botryomycosis. So what do you understand by Botryomycosis? So this is actually a condition which is very similar to mycetoma, but is caused by certain bacteria like Staphylococcus. So your staph can be responsible for something which is known as Botryomycosis, and which looks very similar to mycetoma. Now this is how you will also be able to differentiate them. And one such thing in actinomycetoma, which is caused by Actinomycete pelletieri, is where you see red granules. And white granules in eumycetoma is caused by various other fungi like Acrimonium. Now these are fungi which can also cause your mycetoma, but the granules here are white in color. Now how do you diagnose? Usually the granules are crushed and seen under the microscope, and you see several bacilli, under the microscope. But when you crush granules under the microscope in a case of eumycetoma, you will see more than several millions of hyphae and fungal colonies. So granules here are nothing but microcolonies. So when I am referring to granules, I am referring to nothing but microcolonies of the organism. So these are microcolonies of the organism that you see. Now, coming to the X-ray, so many times they are seen in the ortho OPD with a non-healing wound. So this is normally what is seen. Now here, how do you differentiate is on an X-ray you see osteolytic lesions when it comes to actinomycetoma, whereas osteosclerotic lesions are seen in cases of eumycetoma. So, as understood, it responds well to antibiotics when it comes to actinomycetoma, but it responds very poorly to antifungals when it comes to eumycetoma. Now, these get treated pretty well, but when it comes to fungal, when we're dealing with fungal mycetoma, amputation could be one of the treatments that you have to do in case the infection spreads pretty rapidly. So this is how you see, and this is what I've been referring to when I said that there is tumor-like swelling that you see here. And if you can see, there are multiple discharging sinuses, and many times from these sinuses, the most diagnostic feature that you could see is that there is sandy discharged granules which you can notice. So this is the complaint that the patient usually comes with. So there is a tumor-like swelling, many a times because of some wound that probably he is not even aware of. So he just comes with a non-healing wound, and then you get to see multiple discharging sinuses and also the presence of granules. Now this is what you have to remember pertaining to it. Now, coming to rhinosporidiosis. Now, what do you understand by rhinosporidiosis? Now, coming to the next topic is what is known as rhinosporidiosis, and what are things that you have to remember about rhinosporidiosis. Now, rhinosporidiosis is also an important chronic granulomatous disease. So it's a chronic granulomatous disease, and if you can notice, so it is a chronic granulomatous disease, and most importantly, and the most important complaint that you see is that there are polyps in the nose. So this is the most common complaint that you see. So polyps in the nose is an important complaint that you see. And what is the causative organism that you have to remember? So the agent here is what is known as your Rhinosporidium seabed. So this is the organism that is responsible for causing rhinosporidiosis. Now, what is the source? Where do you get this infection from? So most commonly it is from stagnant water. So stagnant water is an important source by which usually there is a history of people bathing in lakes, and which contains stagnant water again, and there are fungal spores which are there. Now these fungal spores enter inside, or they're inhaled inside when if somebody is taking bath in a contaminated pond or a river. Now this is very, very commonly seen in tropical countries. Okay, mostly it is seen in Sri Lanka and India. So in India it is commonly seen in Tamil Nadu and Kerala, whereas Tamil Nadu and Kerala you also get to see them in various other places, but Tamil Nadu and Kerala are the most important ones to remember. It's also very commonly seen in Sri Lanka. And how do you diagnose? So this is the complaint that the patient comes with, and what is the most important thing which aids in diagnosis is your histopathology. So histopathology is the most important one which is required for diagnosis. So your histopathological examination needs to be done. So histopathological examination is done, and what do you see in the examination? Now that is important. Now what do you see is nothing but what is known as your spherules. Now you see spherules, I'll be able to show you a picture as well. You see spherules. So this is the word to remember, which contains several sporangia, and so these spherules are nothing but sporangia which has endospores. And how do you stain them? Most commonly it's stained by mucicarmine stain. Now these are the things that you have to remember about this particular condition. So like I told you, it is caused by Rhinosporidium seabury, and it presents with bilateral nasal polyps. Now this is the most common presentation that you should know. This is the complaint that the patient comes with. Now they take a biopsy, or your histopathological examination shows presence of spherule with endospores. Now this is the very, very typical finding that you see. And treatment that you have to do is you have to do a polypectomy. So most of the times these people are referred to the ENT department, and they do come with a complaint of bilateral polyps. And it is common in areas where people tend to bathe in stagnant water, and it's common in tropical countries like India and also in Sri Lanka. Now the thing that you have to remember is this is, though classified as a fungi, it is not culturable on your SDA. Now this is an important point that you have to remember. So the organism which is not culturable on your SDA, though considered to be a fungi, is Rhinosporidium seabury. Now they also say this could be a hydrophilic protist. So that is one of the reasons maybe why it is not being able to be cultured on SDA, but yet it is classified as a fungi which causes. So this is sort of a controversy as to what exactly this is. Is it a fungi or a hydrophilic protist? But the thing that you have to remember for the exam is the organism that cannot be cultured on SDA is Rhinosporidium seabury. So this is a case of Rhinosporidiosis. Now the next that we're going to deal with is what is known as your Chromoblastomycosis. And what do you understand by Chromoblastomycosis? So your next important topic is Chromoblastomycosis. And what do you understand by Chromoblastomycosis? This is what you have to know. Now it is caused by pigmented fungi or foured fungi, and it is caused by something which is known as dermatitis fungi. So what do you mean by dermatitis fungi? So whenever I say dermatitis fungi, I am referring to the fact that this is a pigmented fungi. So these are pigmented fungi, and they produce what is known as sclerotic bodies. So this is something that you have to understand. So sclerotic bodies is the characteristic feature of pigmented fungi. So it involves skin and subcutaneous tissues. So there is usually an injury that occurs. So that could be because of a thorn prick, or it could be any other source where you tend to see a varicose lesion or a warty lesion. Now when you do a biopsy of the warty lesion with H&E staining, you see brown colored globose bodies. So I have been talking to you about sclerotic bodies, and these are nothing but brown colored globose bodies. And they form, so these are nothing but fungi which have the characteristic feature of forming brown thick colored wall cells. So they form brown thick colored wall cells which are known as your sclerotic bodies, or also known as medullary bodies. So this is what you need to know. Now these are also known as your muriform cells. So these are the various names that you have. It's called as sclerotic bodies or medullary bodies or muriform cells. Now what is the appearance that you see? It is what is known as your copper penny appearance. This is what you have to remember. So copper penny appearance is what you see. Now what are the various examples that you have which cause this particular condition? Is Alternaria, Curvularia, Bipolaris, Phyalophora and Cladosporium. So there are various other fungi, and these are all phyod fungi. So they are all pigmented fungi which produce the very typical feature of sclerotic bodies or medullary bodies or muriform cells. Now this is what you have to understand for this particular condition. Now Exophyalophora is also another, Exophyala is another important one that you have to remember. So basically the various ones that are commonly seen pertaining to this Chromoblastomycosis is what is known as Fonseca, Petrosi. That's the first fungi that you have to remember. Next is known as Phyalophora varicosa. The next one is what is known as Cladosporium. Carioni. And the fourth one is what is known as Rhinocladiella. Aquospersa. So these are the various ones that you have to remember. Now these are the lesions that you see, and if you can see here, this is what is known as your sclerotic body. Now coming to the next important one is what is known as sporotrichosis. Now this is another important one that you have to understand. So sporotrichosis is an important topic because this is also something that is commonly asked in your exam. So you should be able to know everything about sporotrichosis. Now coming to sporotrichosis, it is also known as Rose Gardner's disease. Now this is an important thing to remember. So it is also called as Rose Gardner's disease because most of the times this is seen as nodulo-ulcerative lesions. So these are nodular ulcerative lesions, and it is caused by your thermophilic or thermally dimorphic. So thermally dimorphic fungus which is known as Sporotrichosis. So it's caused by Sporotrichosis and it is spread by a thorn prick, or usually there is the entry of the spores of Sporotrichosis due to a thorn prick or a splinter injury. So this becomes an important cause. So many times this is seen around Valentine's Day because of the fact that people gift each other roses. So there is a very good chance that there is a thorn prick and the entry of spores which causes sporotrichosis. Now, lymphocutaneous spread is what you see. So this is the most important one that you have to know. So there is lymphocutaneous type and other clinical features that you see, but the most common one that you see is what is known as your lymphocutaneous spread. Now it is a dimorphic fungi where it exists as molds at 22 to 25 degrees centigrade and is seen as a yeast at 37 degrees centigrade. Now what do you see in the mold form? So when you see a growth in the mold form, especially when you see a culture at 25 degrees centigrade, so you put a culture at 25 degrees centigrade, you see a mycelial growth. So here at this stage it's a mycelial growth, and the mycelial growth basically consists of hyphae. So there is hyphae with conidia and a typical flower-like arrangement. So the arrangement that you see here is a flower-like arrangement. Now this is very typically seen in this particular growth. So flower-like sporulation is when there is a culture which is put at 25 degrees and you see a mycelial growth where there are delicate hyphae with conidia along with flower-like arrangement that you normally see. Now, when you put the same at 37 degrees centigrade, so you have to see a yeast form, and this is seen at 37 degrees centigrade, and when you see that, you see what is known as your, so the growth here is what you see as moist white colonies. And when you see them, these are cigar-shaped yeast cells or narrow-based budding yeast cells that you normally see. Now, this is the variation that you see when you put them at different temperatures, and hence it is known as dimorphic fungi. Now, you also see what is known as asteroid bodies. Now, this is something that you have to understand. Asteroid bodies are what you see in your histopathological examination. So when you do your histopathological examination, so this is an histopathology finding, and in your histopathology, what do you see? So histopathology is where you see your asteroid bodies, which are nothing but basophilic yeast cells surrounded by eosinophilic mass. So there are basophilic yeast cells with eosinophilic mass. This is what you commonly see, and this eosinophilic mass that we are describing here are nothing but your antigen and antibody complexes. So these are antigen plus antibody complex, which is seen as eosinophilic mass. So this is what you commonly see. So asteroid bodies are nothing but your histopathological examination, and this eosinophilic mass that I had described to you, which is seen around the yeast cells, around the basophilic yeast cell, is what is known as Splendor-Hopley phenomenon. So when you say you see this particular bodies and there is your antibody complexes which are seen surrounding it, and this eosinophilic halo that you see is what is known as Splendor-Hopley phenomenon. Splendor-Hopley phenomenon. So this is what you normally see. So if you notice here, there is nodulo-ulcerative lesions that you can see here. So this is the typical nodulo-ulcerative lesions. And what you should also remember is that there will be lymph nodes which are also enlarged. So lymph nodes are also enlarged. And the finding here that I told you is nothing but what is known as your Splendor-Hopley phenomenon. So you have your eosinophilic mass surrounding the basophilic yeast cell. So this is known as Splendor-Hopley phenomenon. So basophilic mass is surrounded by eosinophilic material, and that phenomenon is known as Splendor-Hopley phenomenon. Now the next topic that we are going to discuss is deep mycosis. And deep mycosis involves a lot of your other conditions that you see, and this is also important exam point of view. Deep mycosis. Now the first topic that we're going to deal with is histoplasmosis. Now these are all dimorphic fungi, so except sporotrichosis, like I told you, sporotrichosis is a subcutaneous mycosis, whereas all the others that we are going to deal with now when it comes to systemic mycosis are dimorphic fungi. So histoplasmosis is the first topic that we're going to deal with, and histoplasmosis is also known as Darling's disease because it was reported by Samuel Darling. Now it's a systemic granulomatous intracellular infection and it affects the reticuloendothelial system. Now it is caused by Histoplasma capsulatum, which is a dimorphic fungi. So this is what you have to know. So it is a dimorphic fungi which causes histoplasmosis. Now source is usually soil, and which is actually containing pigeon droppings or bat droppings. Now this is what you need to remember. And histoplasmosis is transmitted by aerosol transmission. An incubation period is around 10 to 16 days. Now it involves the lung first and then can cause systemic spread and then spreads to other organs or viscera. Now talking about histoplasmosis, you should know histoplasmosis is endemic in certain areas. So histoplasmosis, though it is worldwide, it is endemic in the USA. So endemicity is, it is endemic in US. So this is what you have to know. And it mainly involves the state bordering the Ohio River. So especially these are of great importance because certain questions will give you an idea about what the condition could be based on the location, right? So that's the reason why you should be able to know what it is. So pathogenesis is mainly by inhalation of spores, and these circulate in the air after the soil is disturbed. So this is what happens. Now after the spores enter the lungs, they are engulfed inside the alveolar macrophages. So you have your alveolar macrophages which are mainly responsible. So you have your alveolar macrophages. So your alveolar macrophages, inside which So alveolar macrophages, inside which you see all these changes that occur. So let's just put that back again. So in the alveolar macrophages, when you see, they are seen in yeast form. So once the spores enter, they transform into yeast form in the alveolar macrophages. Now from the intracellular, so these intracellular yeasts are then transported to the lymph nodes. So from here, it enters the lymph nodes, and from there it enters to other body parts through the bloodstream. So from the lymph nodes, it enters through to other viscera. Now clinical features. So what are the various clinical features that you see? So classically, this is seen in patients with low cell-mediated immunity. So always remember, histoplasmosis is something which is seen when there is a compromise in your cell-mediated immunity. And what are the symptoms that you see? Now, based on the various clinical manifestations that you see, it is divided into different kinds. Now, the first one is known as pulmonary histoplasmosis. So, pulmonary histoplasmosis. Second is what is known as mucocutaneous histoplasmosis. And the third one is what is known as your disseminated infection. So this is known as disseminated histoplasmosis. So these are the three clinical types that you see, and pulmonary is the most common one that you see. So pulmonary disease, now you have an acute form as well as a chronic form. So most of the times it presents with an influenza-like disease, whereas in the chronic form, hemoptysis is an important symptom. Now it resolves within 2 to 3 weeks, whereas in chronic form you have cavities which can be seen. Now lymphocyte-rich infiltrate is seen, whereas calcification is seen in the chronic form. And when it comes to the mucocutaneous that I was talking to you about, so here what happens is you see skin and oral lesions which may develop secondary to pulmonary infection. So there will be a pulmonary disease, but secondary to it you see your cutaneous and your subcutaneous lesions. And what is the most important thing to remember in Indian patients is, so the most important symptom that you see are oral lesions. So they present with oral lesions. This is what is not commonly seen in Indian patients. Now the third is what is known as your disseminated disease, and like I told you, this is usually seen when there is an compromise in your cell-mediated immunity. So when there is a compromise in cell-mediated immunity, that is in untreated HIV patients or patients who have undergone transplantation, you see a disseminated disease. And here it involves various organs like your liver, it involves your spleen, your adrenal glands, various other organs are involved. So the symptoms and what are the findings that you see? So the patient has anemia, leukopenia, and also presents with hepatosplenomegaly, and also has multiple lymphadenopathy. So these are the various changes that you see. Now, what are the specimens that you take first? Now let's get to what specimens should be taken first. So the specimens that are usually taken is your sputum in case of a pulmonary histoplasmosis, or you can also take an aspirate from your bone marrow. So your bone marrow aspirate is the other. And the third is your lymph node aspirate. Like I told you, there is lymphadenopathy, so you can take your lymph node aspirate. And what do you do here? So here you do a histopathological examination, and that is done with the help of your Giemsa stain or your PAS stain. And what you see here is you see narrow-based budding within the macrophages. So you see yeast cells which have narrow-based budding, and these are seen inside the macrophages. So this is a typical feature that you see. So sputum, sternal bone marrow and lymph nodes, and microscopy, you do all this for your microscopy. So if you can understand, the finding that you see in Giemsa stain is what is known as your narrow based budding. So your yeast cells are seen as narrow based budding within the macrophages. Now, when it comes to culture, and this is in fact the gold standard test. So culture happens to be your gold standard. So this is what is your gold standard. And what are the various findings that you see in your culture? Now, this is what you have to do. So your culture, what you normally do is you put a culture on your Sabroth's dextrose agar, and you also put a culture on what is known as your brain heart infusion agar. So these are the two important media that are used for culture, and you incubate this both at 25 degrees centigrade and 37 degrees centigrade. Now, like I told you, this is a dimorphic fungi, so you have to incubate this at both 25 and 37 degrees centigrade. Now, what do you see here in your culture? So in your culture, what you normally see is white cottony mycelial growth, and you see tuberculate spores or macroconidia. So when you happen to notice this at 25 degrees, so this is a growth that you see at 25 degrees centigrade. And now what you see here is the colonies are usually white or buff colored colonies. So these are the colonies that you see, and it contains tuberculate macroconidia, and it also contains microconidia. So tuberculate macroconidia are nothing but your typical thick, if you can see, if you can notice here, it is the typical thick walled finger-like projections that you see. And microconidia are usually small, and these are smooth walled. These are the two findings that you see in your culture growth when you put them at 25 degrees centigrade. Now, what happens at 37 degrees centigrade? If you put this culture at 37 degrees centigrade, so when you put the culture at 37 degrees centigrade, it gets converted into yeast form. And what do you see in the yeast form is you see pasty colonies. So you actually see colonies which look creamy and pasty. So you see creamy white colonies at 37 degrees centigrade. So this is what is normally seen. So to sum it up, at 25 degrees you see tuberculate forms or your finger-like projections, which are nothing but your macroconidia, and also smooth-walled microconidia. So this is your mycelial growth. Now at 37 degrees it gets converted to yeast form, and you see creamy white colonies. Now serology. So you can check for antibodies in the serum. So this is where your antibody testing comes into play. So you check for antibodies in serum. This is one of the methods that you can do, and it is done by two methods, by complement fixation test and what is known as your immunodiffusion test. So you can check the antibodies by these two methods. And the other methods that can be used is what is known as your latex agglutination test, and also what is known as your histoplasmin skin test. So this is where you demonstrate your delayed hypersensitivity, and this is in response to your histoplasmin antigen. So this is what you can also do. And what it shows is it just gives you an idea about prior exposure. So the things that you have to remember are, in mold form you see tuberculate macroconidia and tiny microconidia. So this is mostly finger-like projections, and narrow base budding of yeast cells can be seen in the yeast form. Now this is histoplasmin skin test positive, which is used for serology. So this is about histoplasmosis, and this is in fact very important in questions where they give you a history about a patient's travel to let's say an area in USA. And like I told you, there are certain areas in the US where this is very endemic. So the question gives you history where there is a travel travel history to the US, or the patient has visited a certain area in the US where this particular condition is endemic. So sometimes understanding that it is endemic in certain areas is also very, very important for you to know. So this is the class about histoplasmosis, and we will continue with the other topics for systemic mycosis.